Hi everyone, welcome to this new webinar by the Young Neurosurgeons Committee in collaboration with the trauma section of EANS. And I have to say it's a webinar that creates a lot of expectations from the beginning, and I hope all of you enjoy it. We have a very good panelists today. I will introduce any of them when they have to speak. And before starting, I have to say it's a webinar that I think is gonna give you a lot of information about a new subspecialty, which is the neuroplastic and reconstructive surgery. It was the creation of this webinar was initially idea of Netanel Ben Salom, who is one of our Young Neurosurgeons Committee member, and who is doing a fellowship about neuroplastic and reconstructive surgery. And I think it's gonna be very, very helpful for you. And I wanna welcome the panelists, Netanel Ben Salom, and the Habshiban, Professor David Langer, and Professor Aurelia Perod, and also our roundtable, Miran Lepic and Diogo Bello. First, and say thank you to you for joining us, for taking your time for being today here. And I also want to say thank you to OsDesign, who is sponsoring this webinar. OsDesign is a Swedish company that they are focused on regenerative solutions and design of personalized bone replacement technology for cranial repair. Today, we will talk a lot about cranial repair and different solutions, different options. And during the webinar, we will have also the opportunity to ask Cristel Nardo, who is the director of OsDesign and is in our audience, any doubt or any detail you wish. Some of the speakers and some of the roundtable know the implant, so you have also asked Cristel if you have any doubt or any comment to do about that. Okay, thank you, Cristel, and thank you, OsDesign, for sponsoring and for helping us to continue building our scientific content. And I think we can start. The first talk is the first speaker is Netanel Ben Salom. He is Israeli. He is one of our more known member in the committee. He's doing a fellowship in New York, and he's a fan, a lover of his subspecialty. And I think it's this talk is gonna be very, very helpful to all of you, as it is. To date, I think neuroplastic and reconstructive surgery is still a bit unknown for many of the neurosurgeons, and I think his talk will help us to understand better what a neuroplastic surgeon does, why it's so important, what the patients expect, or why the patients are so thankful about that. I have my idea, and Nati knows it, that I really appreciate this care that they take of the aesthetic part of our patients, and not only aesthetic. And but Nati is gonna explain us much better. Nati, move on. Your microphone is off.
Sorry about that. Do you see my full screen?
Yes.
All right, good. Thank you so much, Marisa, for the kind introduction. And I'm so excited to share what we've been doing for the last couple of years. And that would not be impossible without your beautiful introduction to our society about this trendy and future neuroplastic surgery subspecialty. I want to thank the EANS, OsDesign, and my mentor, Dr. David Langer, that is with us today and going to share some of his experience. And we're so lucky to have him here with us. So let's start right away. I'll try to be concise. It's very hard to summarize a field in just over 10 minutes, but I'll try my best to be as concise as possible and talk about what is neuroplastic surgery, what is the value of collaborating, and how we can push the envelope in the future. And I always like to start my presentation by showing this figure and ask you which one of those patients you think has customized cranial implants. And if you think about a patient or two, try to guess which side it is. And the other question is, which one of those patients has a computer inside their head? And if you're struggling to know which one, we did a good job in neuroplastic surgery to make sure that all those patients actually had underwent neurosurgery, and all of them has customized cranial implants. And this is our goal in neuroplastic surgery, to make sure that patients go outside the world without everybody knowing that they have brain surgery. So what do? We try to bridge the gap between neurosurgery and plastic surgery. We deal with complex neurocranial reconstruction. And by the end of the day, we want to ensure that patients have complete preservation or restoration of their appearance. In fact, if you look at a typical patient, a young guy had a TBI or a stroke, he's going to rehab, he's doing pretty well, come back for a reconstruction. If you look at the literature, you find that 35 to 40% chances the surgery is going to have some kind of complication. And this is why we need to improve that. In fact, if you look at this meta-analysis, 8,000 patients, 8-year-long longitudinal study, 1 out of every 3 patients coming for a cranioplasty will fail. And this is not acceptable in 2022. That's why we need a new subspecialty that is dedicated for adult reconstruction. Why is that? Neurosurgeons rightfully focus on the brain for the last 100 years, and plastic surgery focused mostly on other endeavor. And this is why we need to bridge the gap between neurosurgery and plastic surgery. If you think that I'm biased and I travel around the world to study that, and I drag my family to Baltimore. In fact, if you read this book by Henry Marsh, one of the senior neurosurgeons in Europe, in chapter 11, when he's about to operate on a young patient with recurrent ependymoma, his most concern is how the wound is going to look like. Is it going to be healing well? Treating the brain is not as hard as treating the scalp and the skull. And if you take a female, God forbid, with a breast cancer, she'll see the oncologist and she'll see the plastic surgeon in the same sitting, and then they will formulate a plan to take out the tumor and reconstruct her breast. But when a brain tumor patient is diagnosed, he'll see the neurosurgeon that will schedule for surgery. But then if there are any issues after the surgery, like deformities, temporal hollowing, scalp dehiscence, device exposure, where is this patient going now? And that's a question mark. And we all have seen this, right? Patients come in, TBI, hemicraniectomy, cranioplasty, and then they come in with exposed mesh, severe dents. We see all those, ugly wounds. Who deal with that? For the most part, we'll try to collaborate with our colleagues, but we know that the results are not the best. This, in fact, 2022, a paper I had to review last month, a patient that had a TBI, hemicraniectomy, and exposed mesh, and this is how he was reconstructed. The right lower bottom shows you how a patient in 2022 getting reconstructed after a failed cranioplasty. This is unacceptable in 2022. And we looked at the data and we saw that, the more attempts of reconstruction you have, the higher the likelihood for failure. In fact, 3-fold increase in incidence of major complication like dehiscence and surgical infection if you're going into a place that is not a specialty or does not have a dedicated center of excellence, which I think is mandatory in every high volume academic center. So we are overarching 2 specialty, right? Plastic surgery and neurosurgery. And in fact, today, we can safely say that we've been helping and improving results for both oncology patients, vascular, scalp reconstruction, functional neurosurgery, neurotechnology, and I'll show you some pictures. And this is the take-home message, is to really bridge the gap between those patients that did not have anywhere to go before this field was invented. And this is a typical case. This is a 67-year-old person, had an MCA stroke, hemicraniectomy, recovered quite well. he wants to go back and pick up his grandkids from school, and he doesn't want to look like that. And he come to us and he say, I know the complications rate are very high. Should I do that at all? Should I even consider, cranioplasty? And, we offer this pericranial onlay technique, which we showed really decrease the complication rates. And, in fact, when we look at our 500 cranioplasties, we reduced the complication rate from 36% to 15% and only 8% infection rate. And this result suggested that we really need a designated multidisciplinary team approach to deal with those patients. And this is our results, right? And we published that in the main neurosurgery textbook. Now every resident that start, training, get the Schmidt textbook and can read about that and the algorithm that we developed, in fact, to teach how we can deal with those cases. And that's another case, how we advance the field. This is a 27-year-old guy. He had a TBI, hemicraniectomy, recovered pretty well. He wants to go back to society. He wants to go out to party. He wants to go find girls. He wants to go out to the bar and drink. And he doesn't want anybody to know that he had brain surgery. But in fact, when you look at those PEEK implants or plastic implants, you see that they're doing very good job to reconstruct the bone. But what about the soft tissue defect, like the temporal deformity, which is still an issue with those plastic implants? So our team at Johns Hopkins, look at all the algorithm, how to reconstruct the soft tissue as well, and came up with this design, which we want to augment the temporalis muscle in order to give exactly the same appearance or as close as possible to preoperative appearance. Now look at the guy on the right. You would know that he had brain surgery. He can go out, he can, find a new job without anybody questioning his previous history. Nobody wants to go ahead in society and say I had brain surgery. And this is when we started to push the envelope. A patient came to us after multiple infection due to RNS device, which is essentially an epilepsy IPG to decrease epileptic seizures in 80%. And the patient came in and another patient came in and we said, what can we do to make the device better as all this bone got infected with osteomyelitis? And what we did is we printed a 3D model of the cranial implant and housed the computer, the IPG, inside the skull space. And then by the end of the case, she is a high-functioning CEO. She doesn't want anybody to know that she has an epilepsy IPG in her skull. And those are the results. The Wall Street Journal really enjoyed and liked that, and they came and talked about it, and it was widespread news that we can now house technologies inside skull implant. And that actually turned out another light bulb. This is a patient that came in with exposed shunts. Now we know that shunt is not a good device. It has high profile, it can cause skin erosions, and with time, those devices can be extruded from the scalp. As you see on the left image, this guy came in with exposed shunts. He asked us, what are you gonna do next time? And we said, well, we're just gonna do the same, give you another shunt on the right side. This guy in particular was an engineer, and he said, if I build a bridge and the bridge breaks, I would not build the same bridge again. And we had to go back to our whiteboard and table and think about solutions. And this is when we came up with a cranial remodeling device. Instead of putting the shunt above the skull to press on the scalp, we actually developed a skull implant. And by the end of the case, you see the before, you see the high profile 1 centimeter valve completely embedded inside the skull, and we published that as a first in human. Now, you might say this guy is an engineer, he's smart and whatnot. Well, if you look at the Hydrocephalus Association survey, 72% of patients with shunts suffer from pain with a shunt, and they avoid, doing some activities and sleeping on the side of the head because of discomfort. This is something that as neurosurgeons, we do not think of every day. And there, another case, for example, this, typical case, hemicraniectomy, come back 3 weeks, 3 months, 6 months. When do you put the bone flap back or the implant back? Look at the brain, is swelled, there is ventriculomegaly, is it high pressure, is it low pressure? Well, we found this opportunity. This, young lady came to us after a TBI. She did amazingly, and her mom said, how do I know if you put an implant back on her swollen brain, she's not going to develop pressure? And, we said, it's a good question. So what we did was we took one of those FDA-approved wireless ICP monitors and implanted in the implant. And then if you want to measure her pressure and ICP 3 days, 3 weeks, 3 months, 3 years after surgery, you can just do it with this bedside monitor. And we published that as a first in human experience. And just to summarize how we developed that, we can put computers, shunts, ICP monitors into skull implants. And as Dr. Langer will show you later, we can do some other cool things. Just to summarize, the future is right now, we are here to collaborate and to really break silos. We want to improve those patients' outcome by working together to make sure that we push the envelope. And this is sort of 25 years of advanced technology, from the bag phone to the iPhone X. If you look at the bottom arrow, on the left side, you see those gold, prehistoric gold cranioplasty. Then we used to put the bone flap in the belly. Then we use those off-the-shelf tantalum. Now we can use customized implants with embedded technologies. And we need to push the field forward to not only get better results, outcomes for the patient, but also to advance neurosciences. And that can be a GBM patient, an epilepsy patient, hydrocephalus, or Parkinson's. And we can use the skull space as an unclaimed real estate to develop technologies to not only improve the outcomes of the procedure itself, but to also learn something and have functional technologies embedded inside their skulls. The future is right here. I always say, be the change you want to see in the world. Don't wait for anybody else to do that. And I think we are a group of a lot of good and talented people to push the envelope. And if there is any question or doubt, go ahead, investigate and explore and be the change you want to be. Nothing would be possible without my mentors back in Israel at Hopkins and here at Lenox Hill Neurosurgery that really give me the foundation and the ground to flourish and grow. Finding a good mentor is one of the most important, I think, aspect of neurosurgery, and I've been very lucky to be surrounded by those great people. And thank you so much, really, for the opportunity to share what is neuroplastic surgery and what can we do with it. Thank you.
Thank you, Nati, for your stunning presentation as expected. I want to point out only one thing. I think, like you, I agree with you that the outcome of the patient is not only the outcome of the tumor control or the surgery you are doing. The outcome is also to reduce the infection rate. It's also to achieve a good aesthetic result. We have to think also about the psychological impact of the patient, because the patient not only suffer the bad news of being sick for a tumor or whatever, but also the psychological impact that we live when we don't end our work well, because at the end it's the same. It's just to take care of the repair at the end, to plan it and to take our time doing it or asking the help that we need. Please use to the audience, use the question, the Q&A menu if you want to ask something to the panelists, and I will ask them. Otherwise, we can continue with the talks, and you can ask later, or we can discuss at the end. Okay, let's move on then to the next talk. Our next panelist, Catherine Reve, suffered a familiar issue, and she couldn't join us. But in replacement, I have Professor Shivan is here to talk about cranioplasty. And we think that apart from the point of view of the persons who are dedicated to reconstructive surgery, it's also important to know the regular neurosurgeon, the neurosurgeon who is not dedicated to neuroplastic opinion or experience. So Professor Shivan is going to talk about the cranioplasty in general review, as Catherine was going to do. Thank you, Ehab, for joining, and thank you for taking over so short time.
No problem, Marita. Thank you very much. My name is Ehab Shivan. I'm a chairman of neurosurgery in Augsburg, which is in Bavaria in Germany, southern Germany. I would like to show you how I consider cranioplasty. It's not only a benign disease, as the first talk showed us, which is normally we think this is a procedure that should be done by the first-year resident, but it's not easy, and we need to have more consideration. So This is a strictly academic talk showing the data about different, mostly these two questions, what implant we should use and the timing of surgery. And I looked at the data regarding these two questions, which is, the most relevant questions for us in daily practice. So look at the implant we need or should use has to have some specific characteristics, has to be biocompatible, osteoconductive, osteoinductive, has to have structural bone similarity and obviously mechanical resistance. But it also needs to be, easy to use, easy to shape, even safe and low cost. And if you look at all of these parameters in one implant, the only thing you have is, the autologous bone, but it also has its own limitations. So looking at the data, this is one systematic review looking at all the published data from between 2000 and 2018, comparing bone to synthetic implants, looking at infection, reabsorption rates, wound complication, and resorption. Here you see that most patients, 60% had bone, 40% had synthetic material. There was only one RCT, which I will show you in a few slides. Mostly it was single center retrospective cohorts, so level 3 evidence. Most of the cases were following trauma or ischemic, malignant media infarction. Here looking at infection, it was, there was no real difference statistically, but some higher level cohort studies showed a non-significant increase in infection with bone. Looking at reoperation rate here, significantly more more often reoperations with bone than with synthetic materials. This was also statistically significant. Wound complications, no difference. Looking at resorption rate, which was really alarming because I really didn't know that this was such an issue, because we rarely see these patients on follow-up after a year. And here you see that the resorption rate in total was about 20%, and it varies between the studies, but it's varies between 6% and 40%, and an average 20% resorption rate. So in my opinion, resorption rate is an underreported complication. We don't really think about it on daily practice because many of these patients just do not come for follow-up. Takes up to a year to be symptomatic, and it's more often seen in younger patients after, traumatic brain injury and patients who have VP shunts, and I'll show you the data on that. So if not to use bone, in these cases, what to use? We have different materials: titanium mesh, titanium with calcium apatite, you see here from the sponsor, or plastic, different, or ceramic even. So different stuff. The data is not really very clear, but we have some evidence. This is one of the best studies I found, retrospective single-center studies with a long minimum follow-up for this disease, almost 600 patients looking at bone, PMMA, plastic, or titanium mesh. You're looking at the differences in complications. You see here, obviously, only with bone, you can have bone resorption, 26%. So this 20-25% resorption rate seems to be accurate. With titanium, we had more problems with the skin or bone flap exposure. And with the plastic, you obviously had more problems with infection and also late infection, up to 30%, which is very, very high in my opinion. So for bone, you had the bone resorption, for titanium, the skin problems, and for plastic, the infection problems. Looking at bone resorption multivariate analysis, we see that more often in younger patients. So the younger TBI patient will probably have more problems with bone resorption. That's why, at least in Augsburg, if I have a young patient after TBI, we go strictly to synthetic material and just don't do the bone anymore. So this is to my knowledge, the only randomized controlled trial looking at cranioplasty comparing titanium to bone. Randomized controlled trial. You see, it's a small, really a small number of patients, but still a very well conducted trial. 32 patients for titanium, 32 for bone. You see here the revision rate for bone was much higher and statistically significant. The rate of partially or complete failure after primary cranioplasty with bone was higher than with titanium. And the overall outcome, you see here, complete failure, 20%, partial failure, or complete success was less with bone than with titanium. So you have less revision surgeries if you do synthetic material, in this case titanium, comparing to bone. And the argument we always hear from the controlling that it's expensive, well, not really. If you consider that you are doing more revision surgeries in patients with bone implants, you end up with less cost if you use titanium. You can see here clearly that the costs for the system are higher if you're using bone because you are having more revision rates. So here, looking at traumatic brain injury only, systematic review, 60 studies, almost 10,000 patients. Here, they looked at TBI versus non-TBI, if there are any differences with regards to cranioplasty complications. To make a long publication short, here are the numbers. Overall complications, no difference, but really high, 24%. Hemorrhage, no difference. Seizures, no difference. Hydrocephalus, no difference. But in TBI, we had more infections. Notice 11 versus 8%, and resorption of bone was more seen in TBI versus non-TBI patients. So here again, the 20% bone resorption is still the same number we see over and over again. Looking at now timing of surgery, this is sometimes an issue for the younger patients because you feel obliged to have the cranioplasty sooner, after 4 to 6 weeks. Should we do that? Well, the answer is no. This is a systematic review, 25 studies looking at more than 3,000 patients. Early surgery was defined less than 90 days after craniotomy, and 1,700 patients had a late craniotomy. You see here that there were no real complications, no real difference between early and late surgery. The only difference was in hydrocephalus. If you did the surgery within 90 days, you had a higher rate of shunting, or the patients requiring a shunt. So there was a difference. If you do a neurosurgery, you probably will be ending up using a shunt in these patients. So in summary, the most important take-home message is resorption is a very underreported complication, up to 20% of cases, mostly in younger traumatic brain injury patients. So I would suggest to be more aggressive with buying an implant and putting synthetic devices here, not bone. Early surgery is associated with hydrocephalus. Titanium has the higher risk of skin problems, and plastic the higher risk of infection. So that's why in Augsburg, at least, to avoid these two problems, we're using combination of synthetic materials where we have a titanium implant with calcium apatite on it. So to avoid to have the best of two worlds, and we are now having experience for over a year and a half now with really good results. That's it. Thank you very much. Open for questions.
Thank you, Hab. It's curious to see that autologous bone that we have always think it was cheaper is not cheaper at all.
Exactly.
We have a couple of questions. We have a couple of questions for Nati at the beginning. Nati, are you here? Can you listen to me?
Yeah, I'm here.
With this one question from Dr. Arti Kulov, who say, could you tell me, had you ever reconstruct patients with the comprehensive craniectomy of both sides? And which is the complications rate or any trick? Have you ever done it?
Yeah, that's a great question.
Maybe Professor Langer can also answer to that, or have Shivan?
Go ahead.
Nati?
Yeah.
I'll let Nati go ahead.
Yeah, thanks. So the answer is yes, and basically what I do when it's bilateral decompressive hemicraniectomy, I stage the operation. I would not run for the OR to do a bilateral case, just because if you have an issue, as the Hab said, and the research show with one implant, you want to make sure that you pass the first implant trial, which means you want to make sure that the patient get the implant, the patient does not react to the material that you choose, and you have to choose the right material and then go for the other side. So basically, whenever it's bilateral, I would stage it at least 90 days apart. Patients not necessarily like it, but we showed in our 500 case series that if you stage the operation, you have lower complication rates. If it is a bifrontal case that I have to open the same incision, I will do, you know, the one-stage operation. But that's for bifrontal, you know, craniotomy. But otherwise, I would stage it.
Yes, same experience here. We used to do that in my residency in Munich. We had, you know, the German-speaking audience would notice Deckel shunt pupille, meaning left, right shunt pupil, because we always got into trouble if you did that. So that's why we're now staging left, and then a few weeks afterwards, the right side. And probably first surgery would be one side with a shunt and then sending back to rehab and coming back for the other side.
Okay, thank you. Any other? There are many questions, but if you can excuse me, we can move on. We need to move on to the Professor Langer talk because he's losing the Wi-Fi and he needs to talk before we lose him. So if you all agree, we go to through the Professor Langer talk, and thereafter we can continue discussing. Okay, it's okay for you, Aurelia? We skip you. Okay. Professor Langer, thank you for joining us, and thank you for accepting.
It was conflicted with the vacation. It was, if I told my wife I had to move the vacation for this, that would not have worked out well. So I was hoping she's away from me right now, so we're all good.
Thank you for accepting the invitation, even being on vacation. It's highly appreciated because we know you are a big expert on the topic, and it is a big pleasure for us to have you here. So Professor Langer, I think you all, the audience, know you, but if you let me introduce you, he's the chair of neurosurgery in Lenox Hill in New York. He's well known for his work on neuroplastic surgery. We can say he's one of the pioneers, the pioneer, and he's now training Nati. Hopefully he's learning well. And he's going to talk about something very, very innovative, which is the new materials to use the ultrasound, right? Professor Langer? Okay, let's move to your innovative talk. I'm looking forward.
So here's my talk. First of all, I have to thank Nadi. You know, I may be training him, but he's training me as well. And great partnerships are the way this goes. You know, it's a team sport, and I just have to credit him with a lot of credit for pushing me and giving me a chance to train him, which has been an absolute pleasure. He went over a lot of the things about the idea of neuroplastics. What I'm going to move forward on is that it's about essentially diagnostics, monitoring, and surveillance, and that basically changing the paradigm of the way we may think, maybe not right now, but maybe in a few years or 10 years, about the way we're going to be monitoring patients at the bedside. Because frankly, CT is old generation. If you think about the effects of CT, moving patients, the costs, there are real advantages to have a monitoring technique to be at the bedside. Even just cost and availability in third world countries would be an enormous value added. There's a ton of data and on ultrasound in the brain, you know, multiple papers. Nadi's put together a slide. I can't, there are too many papers here for me to read. But we all know that in neonates, ultrasound works very well. We've used this for neonatal disease for years, whether it's intraventricular hemorrhage or hydrocephalus. This is a diagnostic technique. Here's a choroid plexus papilloma. You know, we've been using ultrasound for years. You know, why not use it in adults? The reason why we haven't been able to is because we've been limited by the skull. And I'm not sure if you're aware, but we do craniotomies. And every time we do a craniotomy, we theoretically have this opportunity to do something. We always put the bone back, or at the minimum put a cranioplasty in, but why not put something in that we can ultrasound through at the same time that we repair the skull? And that's basically the idea. And Nadi was really involved in some of the early evolution of developing PMMA implants. This is just a model of brain phantom. And if you look at the ultrasound on the left, which is no implant, versus the ultrasound on the right with this red circle, really very little difference on the using these phantoms, whether there was you're looking through the ultrasound with an implant or not. And on the right-hand side is what the CTs, the MRIs look like of these same implants. So it's a novel idea. It was proven in the lab. So why not use it in people? And by developing a ultrasoundable implant, we can basically, after craniotomy, place a new cranioplasty that allows us to use ultrasound really anywhere. Here's an ultrasound through an implant showing a ventricular catheter, and just you can see the midline there. You can see the ventricles very well. In our experience, we've been experimenting with these implants. There's actually another from a Belzberg paper. You can see the beauty of these things. Not only can you ultrasound them intraoperatively, postoperatively, but you can see through them in the OR. After you're closed, you can see if there's a clot. You can see the brain. You get a real view, even right at the time of surgery, exactly what's going on, and then at the bedside later on, which is a real advantage. This is actually the first human transcranioplasty ultrasound. You can see there was actually a small subdural here that was picked up by the ultrasound. You can see the implant and the subdural very, very easily picked up through that window. Here was one of the early papers out of Hopkins showing in a cadaveric study supporting the use of diagnostic ultrasound and potentially the idea of therapeutic transcranioplasty ultrasound. So the rationale is, let's put these in, start learning what we can get out of them, and then start using them, particularly in the ICU. We can, if we change the way we think about an ultrasound from just sort of a diagnostic tool in kids to potentially a new device in the ICU, we begin to think of like a neurosurgical stethoscope. We're writing an article about this. In the old days, we used to have stethoscopes around our necks, and we threw those out the window and we had ultrasound. Basically, that's what cardiologists use now. Even looking at the lungs for effusions, things, we're using ultrasound, portable ultrasound. Well, why not bring this to the bedside for our neurosurgical teams? And this is a typical bedside, say, portable ultrasound, hooks up to your smartphone. There are a couple of companies that make these that are in the market, but these wireless portable systems are the future. And when you have them, you can just, with an implant like this, you can begin to look right through it. And this is right at the bedside, see the ventricles and see a ventricular catheter. Make sure you're in the right place. So at Lennox, we've been experimenting with the idea of using these in all sorts of applications. Hydrocephalus, trauma, both custom implants, some small quarter-size implants in all cases versus more larger implants. We use them in tumor and vascular and bypass. This is a typical tumor case. Here's showing tumor recurrence. The idea of you could theoretically drop one of these quarter-sized implants in and then follow the patient post-operatively. And here you can see the tumor cavity immediately post-op, but then within a month, on the lower half of the slide, we were able to identify regrowth in this glioblastoma patient, just really with non-invasive imaging. Sometimes doing CAT scans or MRIs monthly, it's once you see something abnormal, then you can go back and do a definitive test. But this is a great way of just surveillance monitoring. Here, you can see, again, in ultrasound showing a tumor cavity for tumor resection, confirming that you can see how the post-op MRI, you can see a fluid level, and that's seen on the ultrasound as well, very well. And again, we're not replacing these more kind of elaborate diagnostic and more expensive tools. We're just increasing the threshold to use them. If you have a plus-minus situation to use first, then you're not going to use the more expensive, costly, time-consuming weapon, and you can use just the more portable, time-efficient tool. This is a paper from Jan Burkhardt, who's been a real proponent of bedside ultrasound for bypass, showing that these can be very useful for assessing MCA bypass, which is near and dear to my heart. We've done a lot of this at Lennox, looking at bypasses postoperatively. This is just from a portable ultrasound tool where you can see the graph there on the surface and then dropping intracranially. You can actually check these both in the sagittal or the coronal plane and really see patency, hopefully flow. On the lower right, you can see the edge of the implant and then the graft dropping intracranially. which really helps us know whether if it's a plus minus at this point, but it may limit a post-op CTA or even a post-op angiogram. Very often with hyperperfusion syndrome on the left, especially in left hemispheric patients, we're worried about patients with deficits, speech deficits, and we worry if the graft is open. Well, just having a quick look, it may not mean that we're not necessarily doing a definitive test, but it certainly gives us pause to know that the grafts are open and we don't have as much of a concern about the graft going down. Here's a hydrocephalus patient. This is a typical small implant, which you can ultrasound through, showing the left and right lateral ventricle beautifully through a small quarter-sized implant. And then here you can see more examples of these implants and the variety of indications, sizes, and shapes that we can use in order to ultrasound through in the post-op period. There are difficulties with this. You have to come up with better ways of ultrasounding early, especially with fresh wounds. You don't want to take the dressing down and put a bunch of goop on top of a new wound. So we're thinking about ways of maybe creating a dressing that includes the ultrasoundable liquid in it that would go over the wound and stay there until it was safe to take the dressing down. But this is new. This is a new age, and I just have to congratulate Nadi for his earnestness and his energy and really turning me on to the plastics part of this. Erez and I got involved with some of the ideas about bypass and putting these ultrasoundable implants in and using the portable ultrasound equipment. But luckily at Lennox, we have both sides. We have Nadi pushing the envelope on the plastic side, and we're working together to really define a new way of finding ways of imaging that are both cheap, safe, cost-effective, and useful, and maybe in some ways better than we're already doing. And so thank you again. I'm sorry I was on vacay, and but I appreciate this opportunity. And this is the beauty of Zoom. Take advantage of it. Don't put up fake backgrounds. Enjoy your lives. Enjoy your time, and you can still do the things for fun and be academic at the same time. That's the beauty of this new world we live in. So take advantage of it. Don't live like we did for the past 30 years and worrying about traveling and missing our kids and our family and not being with our wives. You can have it all, and you can still have a great life. So that's all I have to say about that. So thank you again.
Thank you, Professor Langer, especially for the last recommendations. Very helpful for me. I want to ask you, let's see if there are questions. Otherwise, I have two questions for you before you leave with your wife and your family and vacation. And I want to ask you about the learning curve. It's too tough to learn to use the sonography with this implant?
I think we're talking about this. Our course in December is about this, that neurosurgeons, we're not really trained in how to, the orientation. It's just basic stuff that is not normalized. We think we know everything. And so, oh yeah, I'll do that. And it's easy. It's not so, you have to spend a little bit of time. Frankly, it's the intensivists, to be honest, that need to learn how to do this. We're not going to be going into the ICUs and doing this ourselves. Now we have to be leaders. We have to be the thought leaders. We have to bring it to our teams, but ultimately it's our teams that are the ones that are going to have to do this, because frankly, they're the ones going to be sitting at the bedside with the neurosurgical stethoscope, not us, right? So we have to be the leaders, think this through, but it absolutely works. And it takes a little time to learn about primarily orientation, sagittal, coronal, knowing you have it in the right position. But when you have a large enough window, these portable devices work. We're working on developing with longevity a little bit of a larger window. It's about I think it's about 20 millimeters. Nadi, what's the new one? 21 millimeters.
24.
24. The one now I think is 18. It's too small for the current windows and the portable ones. We're 24. You can really much see everything, and it's amazing. Like when it works, it really works great. There are some issues. Early post-op can be a problem if you put Duragen in, blood, fluid, if there's air. Sometimes the first 24 hours, it's not as good, which is probably the time you want to use it. But we're just the beginning of this, and we're still learning about how to make it better.
Okay, thank you. Because I think it's very useful, the fact that you are independent and you can do it by yourself, not depending of ordering any MRI or any CT scan, waiting for the radiologist, waiting for the opinion of the radiologist, and it's also cheaper. So it's great. It's good if you can do it And I want to ask you also about the resistance of the implants, because they are special implants, right? To be able to do that. For how long have you been using them? And do you find any complication or any problem?
Implants, they're PEEK. They're the same as made out of PEEK. It's the same. They're not
Same
squishy.
thing. Okay.
Yeah.
Okay, thank you. Any other question from the audience, from the other panelists?
Somehow he pulled it off, Nadi.
You're amazing.
you left all of them.
I lost Wi-Fi during Ahab's talk.
Spanish.
During Ahab's talk, I lost Wi-Fi. I'm like, shit, I lost Wi-Fi.
No, it's good that you text me that. Then now we are moving on for the last talk. Aurelia, thank you for accepting the invitation. I think we cannot talk. Thank you, Dave. It's not we cannot talk about cranioplasty and about cranial repair if you don't mention or we don't give the space that they deserve for the pediatric surgeons, for the kids. And we are lucky that we have Aurelia Perot here, who is an expert on the field. And Aurelia is going to talk about the special considerations that cranioplasty have in children, which is very, very important, right, in the topic. And they are also the kind of patient that we have to consider. Thank you, Aurelia.
Sorry, I had to switch on my microphone. Thanks for the kind introduction. And David Langer already gave me an intro, because as a pediatric neurosurgeon, we are very used to the use of ultrasound, and we have a portable sonography handheld for our outpatient clinic visits too. But coming back to the kids and their special consideration, I have no conflict of interest. The causes of cranial defects are comparable to adults. So decompression after trauma or after vascular insult with swelling, after a tumor like this, or even in inborn deformities like here, a craniostenosis, and we do the same case tomorrow, or after infection when you are losing bone, you need reconstruction. And some special issue is the growing fracture. And for this, I want to show you an example. A late consequence of a trauma in a small child can be a growing skull fracture. And this is mostly due to a green stick fracture injuring the underlying dura. And due to the laceration of the dura and the pulsation of the brain and the CSF, the dural tear increases and thereby increasing the defect diameter. And this is an example of a boy. He came to our clinic when he was 5 with a soft spot in the back of his head. And he had an injury 3 years earlier when he was riding a sledge with his parents, and obviously had a fracture which wasn't observed. And when we did this CT scan at that time, you see the big defect, the brain that was the cavity that was filled with CSF. And this is the intraoperative view, a thinning of the bone. There was no underlying dura. And this means a big reconstruction, not only of the bone, but also of the dura, because this was just gone. And in this case, we used PMMA, which is easy to mold and cheap, so to say. But what is the best cranioplastic material in kids, especially when it comes to cosmesis and also with regard to complications like infection, resorption, hydrocephalus? Is the own bone better than an alloplastic material? And for this, I want to focus with you on the development of the skull, which is important when you consider cranioplasty in children. So with a small child, you still have all the sutures open, the fontanelle is open. You can even use ultrasound to detect fractures or to see whether the suture is open. You can use the anterior fontanelle for the intracranial compartment. And when it comes to reconstruction, you have to consider that we have a very big osteogenic potential during the first 12 months of life. Almost any bone defect will heal and will be rebuilt by the body as long as the dura is intact. So we use this potential for reconstruction in craniostenosis, as I have shown you before. And you can always wait until later if you have a bone defect in a small child. If you consider cranioplasty with a split bone, which is feasible in older children, you might not be able to have this splitting before the age of 4 or 5 years, because the bone initially is like a fibrous bone. It's not with this 3-layer of compactor, interna, externa, and diploe. This will develop not before the age of 3 years. So this is something you have to consider in a child. And when you're worried about frontal-basal reconstruction and possible interference with the frontal sinus, you should know that the sinuses don't start to develop before the age of 6 years. And the frontal sinus is present from maybe 10 or 12 years on. So don't worry too much about sinuses in children. But when it comes to cranioplasty, and when you consider the complication rate in reimplantation the own bone, you have to, this is a very nice retrospective study looking at the risk of infection when you reimplant the bone in a child. It has a significant increased risk when you have an additional VP shunt implanted or any other cranial implant, such as titanium plates, and also when the child is still in a bad condition with ventilation or a G-tube. So these are risk factors for infection. And when it comes to the risk of bone flap reabsorption, and Mr. Shivan already said it's quite high or higher in younger patients than in older patients, the age is really negatively related. So the younger the patient, the higher the risk also that the bone flap you reimplant might be reabsorbed. But also the mode of fixation of the bone flap is of importance. And this is a special issue because usually as pediatric neurosurgeons, we try to avoid any non-resorbable materials, especially in the small ones, because it might migrate into the brain if you consider a titanium plate. So this is sutures or resorbable plates are not a good idea when it comes to reabsorption. And so this is a bit contradictory to our belief that we shouldn't use anything that will stay there forever. The reabsorption rate in children under the age of 2.5 years is up to 50%. And what really matters is the size of the defect. So the larger the bone flap, the more likely the risk of resorption, and especially if it's a trauma patient with multiple fractures. So the more bone pieces you have, the higher the risk it won't heal in. Also, the mode of storage might have an influence, but there is no conclusion of whether fridge or belly is best to store the bone. The mode of fixation I already mentioned, and also the time until you reimplant the bone is of importance. And the risk of resorption is less likely the earlier you implant the bone, but of course the risk of infection is higher if you do it too early, if the patient is not in a stable condition. And also, most importantly, even more than in adults, if you have any kind of underlying hydrocephalus, whether treated or non-treated, this is putting too much pressure either outward or inward with regard to bone healing in. So in kids, we also always should consider a floating craniotomy or a hinge craniotomy. So you keep the bone flap in, either pediculated at the suture, or you just leave it on top of your decompression, so it might heal in as soon as the swelling is going down. Of course, we use the same implant if it comes to alloplastic material like PMMA, I showed you, and also titanium. But as already mentioned, we also see rather often complication in kids with titanium implants. The skin is rather thin in the small ones, so the risk for erosions like this are higher. Then porous hydroxyapatite is a very well known implant. It's considered to cause osteoinduction, but usually it's too thick for reconstruction of a pediatric skull. Otherwise, it will break. PEEK is a very well-known implant material. You can produce it in thinner thickness than like hydroxyapatite. And this is for sure a serious material we would consider. Also the OsteSign, which is a combination of titanium and calcium phosphate, and you can even mold it. Even if it doesn't fit perfectly, it's not so stiff that you can't use it and modify intraoperatively. And then this porous polyethylene was once pretty well, we used it quite often, but it's not appropriate for big defects. It's too soft and it might break. So you see there are there are a lot of disadvantages of these alloplastic materials. And to my surprise, when I went into the literature looking up for studies comparing own bone and alloplastic materials, I came up with this systematic review, which finally included 24 articles with this topic. And they compared 484 patients with autologous bone implantation. There were almost half of the study population. The implantation time was quite variable, from 1 week to 17 months. And they used in almost 3/4 the own bone flap, or in the rest bone replacement by rib or from split galvaria. And the complication rate was really high, 32.6%, with a revision rate of almost 13%. And then they compared another group of patients, which were mentioned in these 24 studies, almost the same amount. Again, a very wide range of reimplantation. In this group, all kinds of implants were used: hydroxyapatite, titanium, PMMA, and so forth. And their complication rate, in summary, over these 24 papers was only 14.2%, so much lower. Of course, resorption was not an issue, as already said, for the adult population. Also, the revision rate was much lower, and that was a surprise to me too, because as pediatric neurosurgeons, we always believe the best material is the bone, because we have a growing skull and it might not grow with the patient when he's small. But the authors considered that a long-term multi-center cohort would be needed to finally make a conclusion on this topic. And they did a retrospective multi-center study and came to the same conclusion, that revision rates are much higher in patients who received their own bone compared to alloplastic material. And because we were not satisfied, we started a multi-center prospective registry in our country, where we include, which is an open registry for all European colleagues, to include patients not only for craniectomy, but also for the cranioplasty. And we hope with this prospective registry, we will gain more insights into which foreign material will be best for which patient and which age group, because this is an important issue. So I hope I didn't bore you too much at the end of this webinar, but cranial reconstruction is important not only for mechanical and functional, but also for cosmetic reasons. And then in children, you have to consider that you are dealing with a growing skull. So as soon as you have an alloplastic material, it might not grow as much as the own bone. And therefore, we as pediatric neurosurgeons, we always try to use the own bone unless the child is older than 8 or 10 years of age, because then you can consider the skull almost grown to the adult size. So there are no definite recommendations with regard to the timing of reconstruction, but when it comes to the own bone, the earlier the better with regard to ingrowth. And what kind of material we should use is really age dependent and also dependent on the size of the defect and the location. And In small children, we always consider hinge craniotomies. So we keep the bone in the situs. We don't remove it. We don't put it in the fridge. And we do not have to go back in most cases for reimplantation. So it will re-ingrowth by itself as soon as the swelling goes down. Thank you for your attention.
Thank you, Aurelia. To be honest, I think you have changed many other thoughts that I had. It's true, I'm not a pediatric neurosurgeon, but I had many. I thought differently about the implants and many of the things you have said. So thank you for your talk. If you want, Diogo from I'm going to introduce you, Diogo Bello from Porto. He's one of our young neurosurgeons committee member, and Milan Lepik from Belgrade, Serbia, who is another of our young neurosurgeons committee members. They are going to join for the round table with all of you. If you want, we can start because one of the questions, Aurelia, was about the implant. If you use bone or artificial implant in pets, but you have already answered. So if you want, we can all start it with the remaining question, which is what do you think about sunken? I think you want to say sinking flap syndrome, the Treffinet syndrome. I think. That's what is
it a question to
questions
me?
wanna say? I think it's to all of you because it's not directly to anyone. What do you think about the syndrome? How do you avoid it, or how do you prevent it? It's for all of you. You can start in the order that you prefer.
In kids,
Aurelia,
in kids, it's not a typical appearance. It's more when you have atrophy of the brain, and usually we reimplant quite early, so to avoid this.
And you have, what do you think?
Well, this is not evidence-based medicine, but it's like what we try. The patient has a shunt to dial up the vent, hopefully with the idea that it might give some kind of pressure for it to progress at least, but I'm not sure. It's not working all the time. So please don't try it at home unless you have good experience.
I can share with the syndrome of the Trefine. Actually, there is a good review by Hopkins about the syndrome of the Trefine, and we theorized and found out that there are three actually mechanisms to decrease neurocognition and neurological deficit, mainly related to the atmospheric air heating on the brain and the bone-brain interface gap that can cause decreased blood flow, local perfusion issues, and even decreased lymphatic reabsorption. And we found out that the only way to treat that is, in fact, cranioplasty. The amount of pressure that hits the brain with all the pathomechanism is being eliminated once you do the reconstruction. And I've seen patients coming in either with hemiplegia or hemiparesis, with severe cognitive decline, lack of attention, problem sleep, positional headaches, and their symptoms are improving in days after surgery. In fact, our brain is not used to be pressured without the skull, and the CSF hydrodynamics is really changing once you do the implant. And this is why we also stage shunt and cranioplasty, because we believe that once you put the cranioplasty, the CSF hydrodynamics is actually getting improved, and many patients might not need a shunt. So whenever you see a ventriculomegaly and a brain that is full, you might say, "Oh, I need to do cranioplasty and shunt together." We stage that because we think that once the bone is back, the hydrodynamics and the pressure around it will actually improve CSF outflow, and then we wait. And if the patient is still not doing well, we will do a shunt. But this is sort of my view of syndrome of the Trefine. And as we said before, it's an algorithm, right? You need to know the algorithm. You need to work in the team, and you need to understand that there is a subspecialty that is very much involved in understanding those issues. And for all of you, in the audience, if anybody has a question or a patient or needs, any kind of advice, I'm more than happy to, to share my knowledge and our knowledge and to collaborate on, on anything. I think that what's unique about that group is that we are sort of people or neurosurgeons from all around the globe, US, Middle East, and Europe, and we do need to share the knowledge. And I think that, like in neuroplastic surgery and complex reconstruction, we have amazing association to be able to share the experience of each and every, each individual in the group. So feel free to reach out if you have any questions related to that. And obviously, what we've been talking about was maybe 1% of what we actually do, but this is more of an overall view of how can we help the patients.
Sorry, Nati, can I ask a couple of questions?
Yes, Diogo, hi.
Hi. First of all, thank you to you all. I think and also Dr. Langer, I think all the presentations were great because it changed, at least in my point of view, a couple of perspectives. Just to get right to the point, you talked about neuroplastics as the difficulty that we have sometimes deciding what is a no man's land, if it's neurosurgery, if it's plastics. You talked about the collaboration that plastics have with certain general surgeons. Do you collaborate on a daily basis with plastics? Meaning, do you always operate with plastics? Do you get them on specific cases? Do you not call them at all? How do you do that?
That's a great question, Diogo. And I think that early in my training, I had the same thoughts as you are. As a neurosurgery resident, I was really baffled by, cases that I didn't know how we're going to treat. Not because we didn't have the expertise, and our plastic surgery colleagues did not necessarily have the expertise. And this is why early in my training, I wanted to find an answer for that. And I found this group in Johns Hopkins that actually developed the subspecialty and offer a fellowship. Right now, after this fellowship, to answer to your question, I've been doing that. I've been doing almost 1 year of research fellowship and another 1 year of clinical fellowship. I think I can, safely say that I can deal with most of the issues. I didn't have time to show some examples by myself together with the neurosurgeons. And why do I say it pretty safely? Because at this point right now where I live in New York, which is a very competitive area, I get referral from plastic surgeons that lost any abilities. Meaning that whenever a cranioplasty fail 1, 2, 3, 4 times, they will send it to me. Just not because I'm special, but because I have this very specific training to deal with a difficult sculpt and sculpt. What happened next is that patients start to hear that there is a neuroplastic surgeon in the service, and they ask me to come in for the opening and the closure and make sure they have no temporal deformity, they heal well, they don't get staples, and they don't get atrophic scars. So luckily I can share my value with any kind of subspecialty, right? For me, my interest is tumor surgery. This is why I'm dual fellowship trained with tumor surgery and with reconstruction. Why? Because I feel that right now with technology, we're so good at taking out tumors and analyzing, all the different aspects of tumor surgery, but we are lacking the reconstructive aspect. And I think that by having the skill set, I can really, hopefully, I can give those type of patients the absolute best outcome. And as you said, and as Marisa said, it's very important for the long-term survival, the patient's well-being. And I think that if patient is happy after tumor surgery, let it be low-grade, high-grade meningioma, and they feel good about themselves, and they wake up in the mirror and they not see temporal deformity or scars or hardware, I believe that their prognosis is better. Right. So to summarize everything, I feel pretty confident right now dealing with almost everything, even the cases that the plastic surgeon would offer, free flaps with, 6-hour surgery, microanastomosis, ICU, and a big stake on their head. We now know how to deal with that in a much, easier and more, dependable way. So this is a great question that, I'm sorry I take a lot of time, but I think that's the way we deal with it here. And That's why I was recruited to start the program here in New York.
Yeah. So what I take from your answer is that we all need a neuroplastic surgeon in all of our departments.
No, I think I have told, Nati knows I'm a big supporter of that. That it's not only because of the technology, it's also because our society is changing and we have to give answer to their problems, their needs. And in the same way that 20 years ago, now it's not acceptable, but it was 20 years ago that a woman with breast cancer, now it's mandatory, it's compulsory to reconstruct the breast, right? Because the quality of the life and the psychological problem and the psychological health of this woman is gonna change if you don't reconstruct the breast. I think on the same way for the kids, like Aurelia does, or in the adults, we have to give answer to that. No, our patients cannot be anymore on the street with a hole here or with a defect on the skull just because they suffer a stroke or whatever. Because every day when they go out to the street, they remember this episode, which was a very, very dark episode for them as well, because it was they were suffering for that, and they are still suffering every day if you don't reconstruct well this hole or this wound or this defect. And it's our job not only to take out the tumor or to put the cranioplasty. Is also our job to reconstruct it and to give a good psychological support to the patient. And we have a lot to do with that. But that's my opinion. I let you. Laura Lipa wanted to say something, and also Aurelia, right? Aurelia?
Yeah, I just wanted.
Say, and then after Laura. Okay, Aurelia.
I just wanted to confirm what you just said, especially even more in children, because there's not only a patient that is just starting life, but you also have the parents, and they are even more critical with regard to scars and cranial defects. So yeah, in our specialty, it was always a goal to make a good closure, whatever kind of underlying disease it was, and to have the best option for the child and his life, his further life. Thank you.
Yes, I agree. In the kids, it's especially important. Also because between kids, they are all the time joking with the other and having fun of the other. If you leave a kid with a defect, every day all the colleagues the mates in the school will be asking him, and the kid cannot forget the episode that probably hit him and his family for some time, right? Laura.
Hi, I'm sorry, I'm on call. I'm sorry, I joined late. Can you hear me?
Yes.
You can hear me, okay. So I wanted to ask Nati and all the others if you do have a protocol for Treffen syndrome to detect it. So we're trying to build a protocol. We already did in my previous facility where I was before, but now we're trying to build a protocol for detection of Treffen syndrome. So before cranioplasty and after cranioplasty, if I think that CT perfusion can help in underlying cortical perfusion, and then with some neuropsychological tests as well to appreciate better the improvements that you have after cranioplasty. And later, I wanted to ask to answer. There was a question in the perfect. There was a question in the question and answer from Dr. Hussein. So Nati will answer. I see Nati will answer to it via email. But autologous bone has the unique complication of resorption. This is something that we have to keep in mind, and this is something that burden all our patients too, that use autologous bone for choice or for need. So this is something that we have to keep in mind always. I'm glad that I was able to contribute to this even later in the day. I'm sorry for being so late, and I think it's been a very nice webinar. I have feedback already from it.
Thank you, Laura. Thank you so much.
There is another question in the audience. What are your strategies to avoid temporal muscle atrophy? Do you try to put plates on the burr holes for cosmetic issues? This is by Stefan Motov.
I would think, can I just say, because when, let's say 5 years ago, when I started my residency, my seniors were doing 2 PhD theses on the cranioplasty, and we submitted one of these papers to Journal of Craniofacial Surgery, which is from Johns Hopkins School of Medicine, and we got quite amazing review from some of, I think, Nati's colleagues now, and they emphasized these techniques to achieve better physical appearance with implants for temporal muscle for with implants for let's say reconstruction of the soft tissues and not just the skull. So I would like you, Nati, probably to describe these techniques, which are very, very important, and I don't think we have had much of a touch with it today.
I would love to. Marisa, is it okay if I share my screen just for a picture of that?
Yes, of course.
All right. I think nothing better than seeing with the eyes, right? So I just want to say 2 things about temporal deformities, okay? 2 things that I want to say is, first of all, are we talking about primary pterional, where you want to sort of, sorry, I'm moving real quick because I wanted to show some cases. So are we talking about primary deformity in order to prevent temporal hollowing? This is one aspect. And the other aspect is, how do we fix temporal deformity, right? So for the first question, what is the right way to reconstruct the muscle after pterional? It's a very good question. And what I do actually, and what we do is we are right now using few materials to suspend the muscle into the bone before closure. It really much depends if we did myocutaneous flap, if we did subfacial or interfacial dissection, but we really have few techniques that we developed to sort of suspend the muscle back, either with an implant or with a bicortical screws to the bone. The other thing that I want to share is, what do you do with patients that come back with temporal deformity like this one? And we are summarizing now a paper trying to classify temporal deformities into 3 stages, which means minor, moderate, or severe temporal deformity. And let me give you an example. This patient is actually, she is working for the fashion industry to polish a portrait. So she sees faces all the time. And then she comes back after 10 years, actually, after low-grade glioma resection. And she said, you know, I cannot wake up, look in the mirror anymore. And I polish people's faces, and I really find it very difficult to look at myself and just to remember, as Marisa said before, the dark period of my life. And she comes in with few problems. One, the temporal deformity on the right side, which is actually grade 2. She comes in with this, you know, as you see on the forehead, the indentation of the implant, or the bone flap, sorry, and she comes in with this atrophic scar. She used to, she doesn't have a long hair, and she doesn't like the scar in the forehead. And every time she looks in the mirror, she really thinks about the, you know, the brain surgery. So what we do first, and it very much depends on the quality of the bone flap. Is it good quality? Has it fused? Is it reabsorbed? What's the quality of the bone flap? And we call it the first floor. And then we decide how to build the second and third floor to reconstruct the temporal muscle. And what we did in this case, we did not change the bone flap. We added another temporal augmentation implant that is made of porous polyethylene. We reconstructed the line on the forehead, and we really gave her a new shape of the atrophic scar. And when you look at the before and after, you see that all her concerns have been addressed. How do we know? We do this 3D designs with a soft tissue segmentation. And we see before surgery on the left side, you see the bone flap, you see the line, you see the screws and the plates, and you see how the soft tissue and muscle have been retracted. And on the right side, we can really compare the volume. So we're working now on doing volume analysis of the temporalis muscle to really try to establish a good outcome comparing the right into the left. And this patient, like other, could not be happier for getting that reconstruction. Listen, it's hard for the patient to come back to surgery after they, what they've been through. No patients want another surgery. But after they understand how the quality of life getting improves, the sentence that I hear all the time, I wish I did it earlier. Okay, so when you talk about temporal deformity, it's pretty complex. The anatomy is complex. The soft tissue is not only the muscle, you have the fascia, and you have the fat. So you really have to accommodate for all those things. And when you build your reconstruction, you have to evaluate the first floor, which is either the bone or the implant, and then build on top of it. This is not an easy case. If you want it to look good, you really have to, have some experience. But overall, this is how we do it. And I think that hopefully, Milan, I answered your question. And I do remember your paper in the JCS.
Oh, thank you.
There is, we have 6 minutes before ending. There is one question in the audience. They ask about the role of stencils in the cranioplasty. Who of you can answer to that? There is any role, any experience in that?
I think there is no point.
I have no, nothing, nothing.
Well,
Aurelia?
We only for trauma in general. We have a big research unit here in trauma, and they do a lot of bone, bone healing and replacement of bone in general by stem cells. But so far, I have not seen anything on this with regard to skull. It's more for the long bones. So sorry, this is all I could add to this question.
Yeah, no, yes, it's the same for me. And they also are asking if how often do you, Nati, when you explained about the when you put this peak about the face, they are asking how often do you bring the ENT for the reconstruction? If you do you call them, or do you
for what cases? Oh, frontal sinus. Oh, I see.
Yeah.
All right. Thank you, Ido, for your question. Basically, what we've noticed that, frontal sinus disease and frontal sinus issues is a really no man's land. Why is that? Because as neurosurgeons, we know that we need to cranialize the frontal sinus, and we have trauma, and we learn how to do that. As ENTs, they mostly cranialize the sinus, work on the sinus when there is anterior disruption or the maxillofacial. So whenever there is, the sinus has two walls, right? The anterior table and the posterior table. Whenever there is a posterior table destruction of the frontal sinus, the discipline that so far learned how to deal with that are the neurosurgeons, because ENTs, whenever there is a posterior table disruption, are not getting really involved with that, because they mostly go through the nose, and the nose can show you the anterior table and the content. What we developed, and we published 2 papers about that from Johns Hopkins, is how to obliterate the sinus in a way that will be not only effective, but very long-term durable. Why is that? We've seen a lot of patients coming back to us with frontal sinus disease, either cement in the frontal sinus, fractures, tumors, anterior skull base, complete anterior skull base involvement of tumors. And we developed techniques to obliterate the frontal sinus in a way that will be long-standing. So I can definitely say that if I feel that I can reach everything from above, which means same incision, bicorona, and can reach everything from above, I usually don't involve the ENTs, just because their expertise on the posterior table is not really there. If I feel that I can really use the assistance of an ENT to go through the nose with the camera to work on the frontal sinus content, something that I cannot do above, I will definitely use them. 100%. I think it's a very fair and valuable skill. But if I go from above, meaning that I can really I can really see everything in the best possible way, I will not necessarily involve the ENT. You know, for the most part, I would say that's at least for my case. But we are good colleagues, and you know, in any case that we bring in a nasopharyngeal carcinoma and enteroscopy stuff, and I need someone to look from the nose, I always involve the ENT. So this is sort of my general answer for that. I don't know how my colleagues here would deal with the frontal sinus.
Have raised the hand.
Well, I wanted to ask already actually about hinge craniotomy, which was for me a new concept. So how big could it be if you leave it in? What's the point? When do you decide when you can do it, when not?
As long as you have open sutures that you can use as a door angle, you know. You can do craniotomies that are angled towards the suture. And it's in children, you always should avoid crossing sutures, because afterwards it's the possibility that the suture wouldn't work any longer, and you will create bone deformity and skull growth deformities due to the impairment of the existing suture. It won't grow in the same way as it would have without being crossed by a craniotome. So usually when we do a decompression, we stay to the parietal bone. If we have to go anterior, of course, then you include it, but you can angle it to the sagittal suture. And this is the best thing to do in the small ones, you know, in the kids under 1 year of age. But I had cases like a shaken baby with an acute subdural. I had to do a decompression, and I was worried what to do with the bone flap if I leave it out. So this was my first case, and it worked fine. Of course, I had to go back to do some dural repair after the swelling went down, because the brain was expanding and then it went back again. But the bone never was a problem with healing in. So it's pediculated, it's well supplied with blood. Why not? I have done once multiple flaps, so to the coronal, to the sagittal, if you need a bigger space. This is for sure an option in kids.
Okay, great.
Thank you. I think
Sorry, just to keep on topic. What about you? We're talking about hinge craniotomies. You talked about also floating craniotomies.
Mm-hmm.
Do you often do those? Do you leave it, you know, with a suture on, or just leave it floating?
Just floating, just on top. It depends on the underlying disease. I haven't done that so often, but in older children where you have not this flexible skull anymore, and you don't want to put a big bone flap into the freezer, and you assume that despite this bone on top, the expansion is enough for the brain, you can leave the bone flap just above, but don't fix it. And usually it comes back down again and heals in quite well. Yeah, I did this in a tumor swelling where I really was afraid to put rigid fixation, and I did it in one trauma case. Yeah.
Okay.
So it's not that we have all big experience, but you have to be creative in kids sometimes. Think outside your box, and my dogma is try to preserve the own bone at least before the age of 8. Yeah.
Mm-hmm. Just one follow-up question about the bone preservation that can go to Professor Shiban as well. We do get some cases that we operate with ENTs because of kids, of course, with the frontal sinus infection and the spreading to the brain. So empyemas. So in those cases, do you always take the bone out? Do you keep it in? You keep it in?
Yeah.
Okay.
Even,
right.
I mean, we had cases where the whole hemisphere was covered with pus, and you open the door and it just spills out. But as soon as you have washed out the pus and you get rid of the initial infection, there is no such big swelling. The higher risk is for venous sinus thrombosis or septic thrombosis. And you will never have a chance to put this bone flap back in again if you don't do it immediately. So I never had a problem to reimplant the bone flap immediately.
Okay. because we changed. Now we do as you do. Our pediatric neurosurgeons are also very keen on keeping the bone. But from the adult side and the older neurosurgeons would always do take the bone out because it will get reinfected. Do not keep it in, which led to the next problem, which is we do not have a freezer, so we still keep the bone flap in the abdomen. And so if we had an infection and we need to take out the bone, it wouldn't make a lot of sense to put it in the abdomen as well. So in that sense, the bone would always go, it would always be discarded, which would lead to the next phase would be to put in a prosthetics. But yeah, thank you for your input.
I just want to say something about it, Diogo, if I may. We found out there is a good paper that found out that if you take the bone out and you freeze it, and before cranioplasty, you take a chunk of it to microbiology, more than 60% will have P. acne, which is a low-grade infection. And we found out that P. acne and low-grade infection can be a very, a severe cause for osteomyelitis with an implant. What we do in the frontal sinus is whenever we have a frontal sinus issue, especially mucopyoseal, right, or mucocele, we'll never put the bone flap back and we'll never put an alloplast. In case, what we do actually, in fact, is we only do a pre-bent, pre-curved titanium mesh. Why is that? Because we feel, and Ehab showed us the report, that titanium mesh is the highest resilience for bacteria. And we know that no matter how good you obliterate a sinus, you always have the risk for communication. So whenever it comes to frontal sinus, and I have, at this point, we have a lot of cases collected, the usage of pre-bent titanium mesh works best. And what we do, we print the patient. So you ask how you pre-bent, you cannot print titanium, right? So we print the patient's skull model. According to the CAT scan, we create a 3D model. And then in the office, we take the pre-bent mesh and we cut it and bend it and shape it to the skull implant, to the model, and then send everything sterilization. And then in the OR, we open it sterile and we have a custom, a customized patient-specific implant for the frontal sinus. I've seen patients coming in with cement in the frontal sinus. I've seen patients coming out with pus and resolved bone in the frontal sinus. I've seen patients coming with hydrocet in the frontal sinus, just because it's never been, I guess, clean and obliterated well. And even if it did, sometimes techniques were different 10, 20 years ago. I've seen patients walking with holes in the forehead, chronic draining sinuses for 21 years because, frontal sinus is an issue. You really have to know how to deal with that. And our algorithm, to somebody's question before, what is the algorithm, is really stage the operation. First stage, clean the frontal sinus, obliterate it, and we obliterate actually with a patient's own bone. No fat, because fat can get necrosis. We use the patient's own bone and pericranium, and if we don't have pericranium, we use the deep temporalis fascia. And then we glue everything down and then let the patient heal for 90 days. Why? Because we both know that now we obstructed the sinus, it comes back, there is no air, everything is clogged. And then we know for the reconstruction, when we use the pericranial on the technique, the chances for the implant to survive for life is the highest. So this is what we do in adults. Pediatric is totally different ballgame, but at least for adults, this is our algorithm, what we've been established now. And unfortunately, it's very new. We really need to spread out our results so other people can use it, because I still see very senior neurosurgeons and craniofacial surgeons that are using those techniques of the hydrocet and the liquid PMMA to fix the sinus, and for the long term, this is not durable. That's our experience.
Okay, thank you. I think that the time is gone. So if you don't have more questions, more comments, we are going to close the session. Thank you again to All Design for the support, which makes possible to share this scientific content. And especially thank you to Nati for giving us the new subspecialty point of view and to make us conscious about how important it is, the reconstructive surgery, to Ehab for giving a general overview of cranioplasty and for taking over in the last minute. Thank you, Ehab. Thank you, David Langer, who is already there buying something in the middle of the market somewhere. for giving us this innovative technology. Say thank you to him tomorrow, Nati, from us. And thank you, Aurelia, for giving us, for updating us about the evidence in pets. Sometimes we are not updated, not the general neurosurgeons. So thank you, all of you, and thank you to the audience, and I want to say also thank you to the office, especially to Anna Rek, who is not here visible, but she is coordinating everything from the beginning, since the beginning. And thank you for your support, for joining. It has been an outstanding webinar. We hit over 100 people at the same time, which is, I think, the best that we have achieved today. So that's a good way to know how good our speakers are, and have a nice day.
Thank you, Marisa. Thank you, young EANS. I'm proud of you all. Thank you, Aurelia, Diolo, Milan, Anna, everybody that was here, Rehab. This was really a pleasure to share the knowledge, and please feel free to reach out if for anything, also for just a drink.
Thank you.
Nati.
Thank you.
Bye-bye.
Bye-bye.
Bye, guys. Thank you.
Bye-bye. Thank you.